Right now, if you have a surgery scheduled in the next 90 days, or if a doctor has recently suggested one to you, I want you to do something before this video ends. Get a piece of paper, write down the name of the operation, and, next to it, write one number, your age. Because here is what 40 years of internal medicine has taught me. The same operation performed on a 45-year-old and a 71-year-old is not the same operation. The body responds differently. The recovery is different. The complication rate is different. And, in some cases, the risk profile flips entirely, from a routine fix to something that should give any thoughtful physician pause. Subscribe to Dr. Harold Whitman if you find this useful to you. The more people who join, the more likely the next person who needs this information actually finds it before they sign a consent form. If you watched my earlier video on the 7 dangerous surgeries seniors should avoid, you know we covered the heavy hitters: coronary bypass, spinal fusion, major abdominal resection, total joint replacement. Today I want to look at 7 different operations, not the dramatic ones, the ordinary ones, the kind your surgeon describes as routine and minimally invasive. Because, in my experience, those are the surgeries where seniors get hurt the most. Not because the operation is reckless, but because the word routine gets applied to a body that is no longer routine. You know the moment I'm describing. You go in for a consultation. The surgeon is calm, confident, kind. They say the words outpatient procedure or we can have you home by dinner. You feel reassured. You stop asking questions. And the truth is, for someone aged 45, those words are usually accurate. For someone aged 70 or 75, those same words can be dangerously incomplete. I have watched too many of my own patients walk into a routine procedure and walk out, sometimes weeks later, with a complication nobody warned them about. Not because anyone lied, because nobody slowed down to translate the statistics into what they meant for that specific body at that specific age. Now, before we go further, I want to be clear about something. What I'm sharing comes from 40 years of internal medicine practice, but it is not personal medical advice. Every individual situation is different. If something here resonates with you, please discuss it with your own physician who knows your full history. That's where real personalized care begins. The goal of this video is not to scare you away from surgery. It is to help you ask better questions before you say yes. The most common assumption I hear is simple. If the surgeon recommends it, it must be necessary. And this is where most people get it wrong. Surgeons are trained to operate. That is not a criticism. It is a description of their craft. When you walk into a surgical clinic, you are walking into the office of someone whose tools are scalpels and sutures. The question is not whether your surgeon is competent. The question is whether the operation itself, in your specific body, at your specific age, is the right tool. So when a patient over 65 tells me a surgeon has suggested a procedure, I don't say good. I ask, what is driving it? Let me show you what's happening inside an aging body before any surgery begins. Your body has 3 reserve systems. Most people never think about. Most people only know about the first, the heart. They know that a strong heart matters going into surgery. But there are 2 other reserves that age more aggressively than the heart, and that determine whether a senior recovers cleanly or spirals into complications. The second reserve is the kidney. By age 70, the average kidney filters about 30 to 40% less efficiently than it did at age 30. That filtration rate, called GFR, determines how the body clears anesthesia, antibiotics, and pain medications. A drop in GFR you cannot feel can become a crisis when surgery floods the system with drugs. The third reserve is what I call functional muscle reserve. Sarcopenia, the natural loss of muscle mass after 50, means an older body has less protein available to heal a wound, less leg strength to walk after surgery, less diaphragm strength to clear the lungs. A 71-year-old with strong-looking arms but thin thighs is a high-risk surgical patient, even if the EKG looks fine. These three reserves, cardiac, renal, muscular, are what determine surgical risk in a senior. Not the surgeon's skill, not the modernity of the technique, the reserves of the body lying on the table. So now let me walk you through 7 specific surgeries where in my clinical experience seniors are most often steered toward operations they may not need, or that carry hidden risks the consent form does not fully convey. First, elective gallbladder removal, cholecystectomy. This is one of the most common operations performed on seniors, and in true emergencies, be an inflamed, infected gallbladder, it is absolutely life-saving. But a large fraction of gallbladder removals in patients over 65 are done for what is called biliary dyskinesia, or for occasional mild discomfort. Here is the mechanism that concerns me. The gallbladder concentrates bile and releases it after fatty meals. When you remove it, bile drips continuously into the small intestine instead of being released in coordinated pulses. In a younger body, the system adapts. In a body over 65, that constant drip can cause chronic diarrhea, fat malabsorption, and in some cases, vitamin D and vitamin K deficiency. Studies show roughly 10 to 15% of seniors develop persistent post-cholecystectomy syndrome. If your gallbladder is not infected and not blocked, ask whether watchful waiting, dietary modification, and bile acid medication might be tried first. Second, transurethral prostate surgery, what most men know as TURP, and its newer cousins. For a man over 70 with severe urinary retention, this operation can genuinely restore quality of life. But I have seen too many men steered toward prostate surgery for moderate symptoms when medication, behavioral changes, and time would have served them as well. The mechanism to understand is this. The prostate sits at the base of the bladder, wrapped around the urethra. Even minimally invasive prostate procedures cause some scarring, and in 5 to 10% of cases lead to retrograde ejaculation, urinary incontinence, or urethral strictures that require further procedures. For mild to moderate symptoms in a senior, ask your urologist whether a trial of alpha blockers or 5-alpha reductase inhibitors has been fully exhausted first. Third, and this one will surprise people, cataract surgery in patients with significant other eye conditions. Standard cataract surgery in an otherwise healthy senior is one of the safest, most life-changing operations in modern medicine. I am not here to scare anyone away from it, but cataract surgery in a senior with advanced macular degeneration, diabetic retinopathy, or severe glaucoma is a different operation. The risk of cystoid macular edema rises. The risk of accelerated retinal damage rises. And the cosmetic improvement people expect, sharper vision, often does not materialize because the retina behind the lens is already compromised. Before agreeing to cataract surgery, ask your ophthalmologist directly. Given the condition of my retina, what visual improvement should I realistically expect? If the honest answer is modest, the calculus changes. Fourth, carpal tunnel release surgery for mild symptoms. Now here's something few people realize. Carpal tunnel symptoms, that tingling in the thumb, index, and middle fingers, are extremely common after 60, and they are often not caused primarily by the carpal tunnel at all. Cervical spine arthritis, peripheral neuropathy from prediabetes, and B12 deficiency can produce identical symptoms. I have seen patients undergo carpal tunnel release with no improvement because the nerve compression was actually in the neck. Before any hand surgery in a senior, ask whether a cervical MRI, a nerve conduction study comparing wrist and elbow, and a B12 level have all been done. If they have not, the diagnosis is incomplete. Fifth, elective inguinal hernia repair when the hernia is small and asymptomatic. Here's a test I want you to try. Stand up. Place your fingertips just above your groin crease on either side. Cough firmly. Do you feel a soft bulge that pushes outward? If yes, you may have a small inguinal hernia, and statistically, many men over 65 do. The traditional teaching was, every hernia must be repaired. The modern data is different. For a small, soft, painless hernia in a senior, the annual risk of strangulation, the dangerous complication, is well under 1% per year. The risk of chronic post-surgical groin pain, by contrast, is around 10%. For small asymptomatic hernias, in patients over 65, watchful waiting is now considered a reasonable option in major surgical guidelines. Sixth, lumbar discectomy and laminectomy for back pain without clear neurological deficit. This is the one I want every senior with back pain to hear carefully. The mechanism matters enormously. Disc surgery works well when there is a clear, compressed nerve causing weakness, numbness, or loss of bowel and bladder control. What surgeons call a true neurological deficit. Disc surgery works poorly when the symptom is pain alone, even severe pain. The reason is biological. After 60, the discs in your lower back show wear on imaging in roughly 80% of people, most of whom have no symptoms at all. Operating on a disc that looks bad on MRI but is not the actual pain source produces what is called failed back surgery syndrome in 20 to 40% of cases. Before any spine surgery, ask, do I have measurable weakness, measurable numbness, or measurable bowel and bladder change? If the answer is no, the surgical case is much weaker than it appears. Seventh, knee arthroscopy for degenerative meniscal tears. Multiple high-quality randomized trials over the last decade have shown that arthroscopic surgery for degenerative meniscal tears in patients over 50 produces no better long-term outcome than physical therapy alone. Let me say that again. Multiple randomized trials. No better outcome. Yet this surgery is still performed hundreds of thousands of times per year on seniors. The mechanism is straightforward. After 50, meniscus tissue degenerates as part of normal aging. Most tears seen on MRI in seniors are not acute injuries. They are wear patterns. Cleaning them out arthroscopically does not address the underlying arthritis that is the actual pain generator. If you are over 60 and have been told you need knee arthroscopy for a meniscal tear, ask for a 6-week supervised physical therapy trial first. The data supports it strongly. Let me tell you about Frank. 71 years old, retired construction supervisor in Ohio, came to my office 2 years ago with a 6-month history of right knee pain. An orthopedic surgeon had already told him he needed arthroscopy for a complex meniscal tear seen on MRI. Surgery was scheduled in 3 weeks. Frank came to me for surgical clearance. That's the only reason we met. When I read the MRI report myself, I saw what the surgeon saw. Yes, a degenerative meniscal change. But I also saw moderate osteoarthritis throughout the joint, bone marrow edema in the medial femoral condyle, and early chondromalacia. The meniscus was not the pain. The meniscus was a finding. The pain was the arthritis underneath. I asked Frank to delay surgery by 6 weeks and try a structured protocol. By the end of week 1, he had reduced his anti-inflammatory dose by half. By the end of week 2, he was walking without his cane for short distances around the house. By the end of week 3, he reported his pain had dropped from a daily 7 out of 10 to a 3 out of 10. He canceled the surgery. 2 years later, he still has knee arthritis. He still has good and bad days. But he has both his menisci, and he never had to take 6 weeks off to recover from an operation that, based on the trial data, would likely not have helped him anyway. So here's the framework I share with my patients before any elective surgery after 65. I call it the 5-question pre-surgical pause. Question 1. What is the specific complication rate for someone my age, not the average across all ages? This number is almost always higher than the surgeon's general quote. Ask for it. Question 2. What is the non-surgical alternative, and what happens if I try it for 6 to 12 weeks before deciding? For most of the surgeries I just described, this trial is medically reasonable. Question 3. What does the recovery actually look like for someone my age? Not the brochure version, the real version. How many weeks until I can shower normally? Drive? Carry a grocery bag? The honest numbers are usually 1.5 to 2 times the brochure numbers. Question 4. If something goes wrong, what is the most likely complication, and what does it require? This question forces a real conversation about risk that consent forms gloss over. Question 5. If your own mother or father were 71 and in my exact situation, would you recommend this operation today, or would you wait? Surgeons are generally honest when asked this directly. These 5 questions take about 10 minutes to ask. They have, in my experience, prevented more unnecessary surgeries than any single tool I have used in 40 years of practice. I want to close with something hopeful. The aging body still has remarkable capacity to heal, to adapt, to recover function, often without surgery. I have seen patients in their 70s and 80s walk away from operations they were told were inevitable, and live another 15 good years on legs and joints and organs they kept. Surgery has its place. It saves lives. But surgery is a tool, and tools are only as good as the judgment of the hand that picks them up. Your judgment matters here. Your questions matter. The pause matters most of all. How old are you? Write your age in the comments. The age of this audience genuinely shapes which topics I prioritize next. And, if you have ever postponed a surgery and were glad you did, or wished you had, I would like to hear that story too. Your experience helps the next person who is sitting in that consultation chair wondering whether to sign. Share this with someone who has a surgery scheduled in the next few months. They may not thank you today. They may thank you in 6 weeks.